Okay. So, welcome everybody to the Merton CCG governing body meeting. What I'll say at the start is we have a very full agenda, and in my opinion there's a few items that will take a bit more than their allotted time. So I'm going to try and move us through the agenda pretty quickly, and I will allow reasonable time for discussion and debate, but not open-ended time. So if you feel I'm chairing more firmly than perhaps I normally do, that's why. I'd like to particularly welcome Katie Denton, who is now our Director of Primary Care Transformation. That follows Andy McMyler having moved up into a South West London role where he's supporting primary care and specifically supporting Sutton CCG. So you're very welcome, Katie. We somewhere have a list of apologies which has moved away from me. Can you just remind me who's given apologies in advance? Okay, so Claire Gummett, and she's emailed me through a few comments in relation to some of the agenda items with some particular questions, and I know I've passed those on in advance to members of the team presenting. James Blythe is at another meeting, so he's not here. And we haven't got any other apologies apart from that, no. Okay, so let's go on then to the declarations of interest, which is the first attachment we've got. Are there any inaccuracies or changes, or are there any particular declarations of interest that aren't captured here that are relevant to things on the agenda?
Not relevant to things on the agenda, but just it will need to be updated to reflect me rather than Andy.
Fine, okay, noted.
Andrew, I'm no longer the East Merton locality lead, so just need to put an end date, I assume, to that.
Yeah, so we would change that to reflect the fact that your role as locality lead has ceased, and we'll then need to,
I think it has to stay on because it covers part of the year, but I think you just put an end date.
That's right.
Yeah.
Thanks, we'll sort that out. And I know that my one, as it has in a number of other meetings, says Chair of Wandsworth CCG governing body, which isn't correct. So if we can correct the master copy so that that's consistent across all the meetings. Anything else? No? Okay, let's go to the minutes of the last meeting then. So this is to approve them for accuracy. Can I take them as a whole, and can you let me know whether there are any particular issues? Andrew?
Self-effacing though I may be, I actually did attend this meeting.
Yeah, you're completely missed off, aren't you? Well, I'm sure we can correct that. You definitely were there. Is there anything else? Are we happy that they are an accurate record of the meeting? Yes, okay, I'll take those as approved. So, I haven't got any actions coming from that, and there aren't any matters arising logged for me. Are there any particular matters arising that people felt we needed to discuss that we're not covering in the meeting? No? Okay. So the next thing is... Yes. No, I can do that without my notes. So, thank you. Yeah. So this is a paper that is proposing that we appoint Andrew Otley to the governing body. So, as you probably know, we've recently been through a process where we have refreshed our locality lead roles. So we went out to advert and to recruit for those roles so that we could make sure that we'd given people an opportunity to apply, and that the practices were happy that the locality leads were representing them. We've ended up with shared posts, so with 2 locality leads for East Merton, 2 locality leads for West Merton. And when we advertised, we said with a view to coming onto the governing body to reflect the arrangements that they've got in Wandsworth, but that we were going to stagger that. Tim and Karen still have active terms on the governing body. So if we wanted one of them, and what we're proposing is Dr. Andrew Otley, who's one of the East Merton GPs, to join the governing body, we'd need to co-opt him, and we've got provision in the Constitution for that. So that's the proposal in this paper. So really it's to check whether people are happy with that as an approach.
I think we need that approved by the governing body, so.
Yeah.
Yeah.
So what do people have views on that? Is that something people are happy to approve? It reflects discussions we'd had in the past about trying to strengthen clinical representation. I don't know if you remember, but previously we'd gone out to advert to try and get a third governing body GP and weren't successful. Tim?
It was really just for the sort of newer members of the governing body, or the lay governing body members who don't know Andrew Otley as well, who's obviously been an incredibly long-standing member of the East Merton GP fraternity, as well as being heavily involved in the CCG since its inception with mental health. So I think it strengthens our mental health voice, which I think is very important currently, and not just our wealth of experience from the east side of the patch to match Karen's experience. So it was really just to reinforce from the clinician's point of view, for those that don't know him as well, he's a really valued member of the team.
Okay. So looking at nods around the room, am I confirming that we're happy to approve that? Okay, excellent, thank you. Fraser, is it possible to get a paper copy of the papers? My Surface Pro seems to not be servicing me particularly well. Thank you, Sarah.
Cheers.
Thanks. Yeah, so the next thing on the agenda is the chair's update. I'm assuming that you've read that, so I'm not going to go through it point by point. I guess what I did want to pull out was just a reminder about the annual general meeting on the 27th of September. And then I also wanted to draw your attention to the locality lead appointments, which I've just referenced. And then finally, the governing body nurse. So Julie Hall has stepped down from the role, and we'd been out to advert, and we're very pleased to be able to appoint Sam Page, who is the existing governing body nurse at Wandsworth CCG. So she's going to cover both roles, which I think it will help us in terms of joining things up, and it will prevent duplication in certain areas. So I think that's really positive, and she did extremely well in the interview process. At the moment, we're just waiting for all the HR side of things to be sorted out, and she will join us very shortly. So I'm expecting her to be in place for the next meeting. Did anyone have any questions relating to the chair's update? No? So then we have the managing director's update. Do you want to cover that, Sarah?
Yeah, I'm going to cover that, and I'm just going to do one update, including my update. So I'm not going to pick out, again, I know that we want to leave time on the agenda for other things. I'm not going to go through every point. I would just bring your attention to the strategic focus at future governing body meetings, which has been, that's followed a discussion that the chair and lay members and others on the governing body have had around how we bring together a more strategic focus at governing body level. And I think today we are looking at mental health later on the agenda, and I think that's one of the areas that we want to spend some time on. We may not get this right first time. I think that was the message, and that we actually might want to reflect whether that's working for us, and just make sure that we take that forward in a way that makes sense for the governing body. We've already mentioned that Andy is moving to do a role in South West London. The other area that I was going to highlight is IAPT, because we have had lots of discussion at governing body, and we are making a huge amount of effort to ensure that we achieve targets on the IAPT. And you'll be aware that we have now signed a number of new contracts to support the existing provider, and we are seeing some improvement. I would say it's not good enough yet, so we still know that there is more to be done on this, but just so you're aware, that process is in train and happening. And I was going to kind of leave it there, but I'm happy to take any questions on any parts of this update.
The workshop for St George's.
Andrew, can you press your button? That's all right.
Sorry, this new technology is a bit too much for me. Yes, this St George's workshop. I mean, I did raise the question at the previous meeting that we had about, is there going to be a convener of that group rather than just a kind of free-for-all workshop?
No, so my understanding, and we'll probably agree this outside, is that we have chairs of both the St George's and the CCGs, and Wandsworth is the lead commissioner, that there will be some kind of joint chairing arrangement with St George's and the CCGs, and that we have an agenda set out. It's very much our opportunity, because we haven't had a huge volume of board-to-boards with George's, so this is an opportunity for us to build relationships and to develop how we work together going forward. So it will be between the chairs to
facilitate.
To facilitate and manage that. Yeah.
Are there any other questions about the Managing Director update? No? Sarah, is there anything you wanted to add as a accountable officer?
Can I just add, so not directly within this patch, but definitely a very positive thing for South West London, that Kingston University Hospital Trust has been assessed by CQC as having some outstanding services. I think it's the only trust in London to have been assessed as outstanding by the CQC, and I think that is something worth us congratulating them on across South West London, so I just wanted to mention that.
Thank you, Sarah. Okay, let's go on then to the first main item on the agenda, which is mental health services. And Josh, you're going to
I was just wondering,
take us through that, are you?
given we're then technically 45 minutes ahead, Patrice was going to come and join us for this item. Could we take the strategic items first? I've emailed Patrice to let him know, because I could see that developing.
No, that's
but I'm
fine.
not sure if he's able to, how early he's able to get here.
Okay, yeah, that's
Is
fine.
that okay?
Yeah, we'll go on to that.
Okay.
So let's skip then to 7.1, which is the South West London Health and Care Partnership update. Sarah.
Thank you. So this is, we had promised that we would bring a regular update from the South West London Health and Care Partnership. This is kind of the first one in this format, and what this will be going to every organisation in the partnership, remembering that the Health and Care Partnership is across organisations. It's commissioners, providers, it is our colleagues in the local authority who are part of the partnership. I'm not going to go through all the detail, but I did want to do some introductions and some thank yous. Firstly, we have appointed a new independent chair to the partnership, who is Cheryl Coppell, OBE, who you will see a lovely picture of in this report, and Cheryl will be joining us in the next couple of weeks. She's got a huge amount of experience as previously a local authority chief executive in North London. She worked on what was the development of an accountable care organisation across Barking, Havering and Redbridge, so she worked with health and care there, and she's also been a non-executive director at Hillingdon NHS Trust, so therefore she has a huge amount of experience across the system, and I'm sure will be a great asset to us in South West London. But I also want to put forward my thanks to Dr. Andy Mitchell, who has for the past 12 months helped us by chairing the programme board, and Andy has also been involved with the work of the Clinical Senate and coming along to those meetings, and so we do thank Andy for the work he's done. Also, John Galston, who is the Chief Executive of Croydon Healthcare, is retiring at the end of September. John was the provider representative on our kind of quartet for the partnership, and he will be replaced on that partnership by Anne Radmore, who is the Chief Executive of Kingston Hospital, and she will represent all providers, NHS providers, community, mental health and acute, as part of that quartet. So I wanted to thank John and welcome Anne. So what you've then got in this report is two specific pieces of work around estates and workforce, to give you a bit more information. You will hopefully recognise the then local work on local transformation boards and local health and care plans, and then there's a small amount of information about some of the South West London work stream. So I wasn't going to give you the detail on that, and we're happy to provide more information, but we thought it was better to kind of go with less is more and give you a small amount of information about a lot of things rather than trying to bombard you with pages and pages of information. But we are happy to receive feedback and make any changes to this necessary. Oh, sorry, there was one other thing which I think is really important, is children, young people, mental health, which you'll be aware of we've had as a priority across South West London, and particularly we've done a lot of work, you know, led by Andrew as part of the trio of leaders across South West London looking at self-harm, and we've been invited for Sutton, Merton and Wandsworth to apply for first wave funding for the new green paper around children, young people with mental health as a trailblazer. We are very keen that South West London is at the forefront of this. This is a lot of money. It's going to be millions of pounds that will help us to work with schools and will mean that we will be able to reach the kind of volume of young people that we wouldn't even have thought about, I think, unless we had done something like the Trailblazer. So we're really keen that we are successful in that. We want everyone to lobby for us to get this, and we will expect to roll this out to the other boroughs in South West London if those three are successful.
Thank you, Sarah. Did anyone have questions for Sarah on anything in the report or on the report itself? Karen?
I just like to say I think it's very, very clear. I quite liked it. I think it's in very sort of plain English, and the bullet points and the way it's laid out I thought was very easy to read. Thank you.
Anyone else? No? Thank you, Sarah. I think it's a really good format, and I think it's really helpful in terms of setting out what the key areas of progress are, and it's really encouraging. So thank you for that. Let's go on to the next item on the agenda, which is for discussion, which is the commissioning intentions.
Thank you. You will all have two papers that I'm going to refer to in this item. The first paper is a draft of the South West London commissioning intentions letter to providers of services. So to remind in terms of process, ahead of each commissioning round, we have to indicate to the providers of all of our services about the elements of their services we want to change, or where we think there will be impact of some of our work upon them. So for example, if we were doing a piece of work around supporting people in care homes, we may want to indicate to providers that it might reduce the demand on London Ambulance Service, it may reduce the amount of people being admitted for a fall, and so on and so forth. The letter is written once for South West London, partly to reflect the South West London strategy and also some of the work being done at a South West London level, but also to achieve an aligned approach between all the CCGs in South West London with our providers. This is the same approach that we took last year. The format is very similar, if you can remember this time last year. It's almost exactly the same, again for continuity, but also we did very well in our contract negotiations with providers this last year in terms of them accepting our commissioning plans into their own planning assumptions. And I think having an aligned approach up front really helped with that piece of work. So that letter would get sent to providers in early October. It's going to be signed off finally by the committees in common in early October. So in terms of the two asks of the board, I'm asking for comments on that letter and its content either today or over the next couple of weeks as we draw up a final version. The second document is a slide deck that articulates our current thinking around commissioning intentions in the context of the Merton Health and Care Together programme and the Merton Health and Care Plan. And this, I think, just to remind the governing body, this is the first round of commissioning intentions for Merton in that context. And in essence, what the Merton Health and Care Together programme is a collaboration between all the commissioners and providers of services for Merton to jointly plan and deliver service change in a certain number of areas of focus where working together across all of those agencies can make a real difference. I won't go through the paper in detail because I know we have limited time and people will want to discuss the content, but just to draw your attention to some of the key messages coming through from the recently refreshed Merton Story or Joint Strategic Needs Assessment, particular messages there around the importance of emotional well-being and mental health in our population, being able to support people's well-being and independence, to focus with the demographic changes that we're seeing, the ongoing focus that's required on long-term conditions, but also the complexity of those long-term conditions, and that we need to take a holistic approach, not just a health-based approach. We need to look at people as individuals and have an assets-based approach to care. In addition, we have done a number of engagement events, and we have quite a significant programme of events and meetings over the next few months. In particular, there's going to be a large-scale deliberative event in, I think, mid to late November, which will be launching the Merton Health and Care Together programme and seeking community, staff and stakeholder engagement. However, so far, we have some fairly consistent messages coming from the engagement we've had to date. That says that continuity and accessibility of services is really important for people, particularly for those with long-term conditions. There's been a lot of support in all the meetings we've been to so far around the idea of integrating health and social care services, with some pushback. The services don't always feel as centred around the person as they should. People do want to see how services can support them to maintain and improve their well-being, as well as fix ailments, if you like. And also, very clearly, as we've covered a lot in this board, and we'll cover in much more detail later, mental health is a clear priority. In addition, we know we have some quality, performance and financial context to work within. We know that we have to develop efficiencies from the work that we do, and we seek to do that through improving quality. We have some issues with some of our local providers. We have ongoing waiting times issues with St George's Hospital, for example. We need to make sure that our plans help support the solution to that, rather than make it worse. So the next couple of slides, so I'm referring here to in the large pack, slide 118 and 119, give a couple of cuts of a plan of a page of what this means for Merton. And what I'm hoping that you can see for this is how we've carefully considered what the community is telling us about current services, what the needs of the borough look like via the JSNA and the Merton story, and our performance, and how that filters into the priority areas which are outlined on the next few pages. I won't go through the detail of the next few slides because I'll take them as read, but that just outlines where the area of focus is likely to be, what we think the likely impact is going to be. The one thing I would say this is of course a work in progress. You know, this was a slide deck developed in mid-August. The contracting and negotiation round starts in earnest in the next couple of months. There's a lot of work to do to turn a lot of these areas into fully fledged plans and business cases. Although having said that, a lot of this builds on successes that we've seen in year. There's also a section in here that identifies that whilst we have areas of focus in the Merton Health and Care Together programme where we think a collaborative approach across all partners is important, that is not the limit of what we're doing. So the back end of the slide deck just gives you some information on the programme of work, particularly around plan care redesign, urgent care and elements of mental health. And then I just end on just to reiterate the engagement and co-production point. So we will be going to probably more like 30 actually various community and patient groups throughout the autumn to continue engagement on this. We will engage also using our locality structures and reaching out to our member practices, and there will be this large scale event which says in late October here. That's actually going to be more like mid to late November. That's an example of something that's changed since the slide deck was written a couple of weeks ago. So the next steps, the commissioning intentions letter is finalised by the end of this month to go out to providers in early October, and then we start our discussions with providers and ongoing engagement on delivery plans basically from now until March, where hopefully we can be in the position where we're implementing a lot of this work and reaping the benefits.
Thank you, Josh. Well done for getting through that at some pace. Just to give you some feedback from Claire, who can't be here, but she did. She sent an email in advance. She talked about the tremendous amount of engagement work that is taking place, and she was welcoming the fact that questions to the groups right from the start had been asked without any preconceived ideas. I think she was talking about, I think a question was asked to the patient engagement group that we have at the CCG, and she was referencing the fact that the PEG are going to be involved in developing them over the next couple of months.
Yes.
So she seemed to be feeling very positive about how that's going. I just wonder if you could describe how does the engagement work that we're doing fit in with the quite tight timelines we have to notify providers, and how much do we feel that the engagement work is going to reshape or change our commissioning intentions? Are we saying that what we've got at the moment is already informed by a fair bit of engagement work? And when we go out, are we testing that, or are we telling people what we're doing?
Yeah. Okay. So the word that Claire's referring to is, so earlier in the cycle, before we get into the sort of more business end of the year, we've been asking people basically two questions. One is, what is it around current services that you really value, and what is it about current services you'd like to see improve? And left it as unstructured as that, and not really actually caring too much whether the feedback we're getting is about services we commission or someone else might commission. Because if someone has a really good experience of a local authority commission service, for example, then we can learn from that and seek to build that in. The way it's being fed into the commissioning cycle is that as each of these events is held, they're written up swiftly, they're circulated within the team, where we're going to groups with a particular specialism. So for example, there's the Learning Disability Forum next week. We'll be taking some of this work to the commissioners for that area will also be attending directly. In terms of your question as to how is it influencing, so a lot of the themes that are coming out I don't think would really shock anybody in particular, and a lot of the work that we've been doing around integration, social prescribing, increasing our investment in mental health, linking mental health care with physical health care and long-term conditions much more, part of the reason we're doing that is those are some of the messages that we've heard in the past. What we're finding in the events themselves is people do want to talk sometimes about a slightly more operational level of detail because they directly experience the service day to day, and where that's happening we're feeding that into the commissioners. So later on in the year, where business cases start to be developed and these commissioning intentions harden into commissioning plans that go into contracts, you should see in that how this process has informed the initial ideas and refined their delivery is my intention. And what we've committed to the PEG is that the patient engagement group, is that we will engage them throughout that process. We'll also bring them a report back at some point next year that looks back and says, did we actually achieve what we thought we'd be able to?
Next question. In your engagement activity, what are the numbers of people involved in actually giving you feedback?
So I don't have that to hand, but I mean, we will be talking to hundreds and hundreds of people over the autumn about this, and one of the areas of conversation in the Merton Health and Care Together programme has been how do we build an ongoing co-production strategy into the work we're doing for now, because I think whilst we are doing quite extensive engagement, and I think maybe at a better stage to a better quality than we might have done in the past, it's still relatively traditional and we can build on that some more. But we will be talking to a significant number of people, and we're taking very great care to make sure that we're talking to as representative a group of people as possible. Yes. So
Julie, did you want to come in on that?
Yeah, it was just to say that the patient engagement group that Josh has alluded to has got many people. We might have a room of 20 representatives, but they represent an organisation, so they often feed that information back to them, and we'll put on various engagement sessions with them. But just an example of what Josh has said is when Patrice came to the PEG and he talked about the possible plans for mental health, and he was very, very open with the group that what did they want. He didn't take anything that was already prepared and proposed. He wanted to hear from the group themselves as to how they felt, what kind of things we needed to look at, and whether some of his ideas were the kind of things they wanted and on the right track. It went down extremely well that it was put to the public in that way, rather than, oh, this is what we're going to do, what do you think about it? And he did make a commitment then that he would talk to individual groups, he would do face-to-face phone calls, and that we would continually take that back to the PEG for them to have updates on how that was progressing. And I think that's exactly how we need to do it, rather than taking something that's Commissioner CCG led, but not really something that we've engaged with the public with. So I'd like to think that that's how we as well continue going forward throughout every pathway that we're looking at.
Sarah, did you want to come in?
Yeah, I was just going to highlight the fact that we are bound by a slightly artificial timetable around the kind of national NHS contracting round, which means that we have to put formal commissioning intentions into our providers. But that doesn't actually bind us to making changes mid-year, to working with our providers in a different way. And I think that's really important. So we are engaging with people on this, but it's our intention to engage all year on everything that we do around how we change services and how we work with our public and our services. So it's important that we get this right, but what's most important is that if we've got a really clear strategic intent around services and that we talk to our public about how we do that and we co-produce it, we can do that throughout the year. And often when you read some of these commissioning intentions, they're very high level. We're going to do something around outpatients, but then we will go away and do the work with the public and with everyone around what does that look like and how do we implement that.
Thank you. Dagmar?
Yeah, I just wanted to add a little bit that more and more what we are doing is health and care, so integrated approach between health commission services and local authority commission services. And as a health and well-being board, for example, we are trying to experiment almost with how do you keep that rapport with your community, and the Diabetes Truth Programme was an example where we try to do engagement, buddying up senior people from the board with people who have the disease. So there is a lot happening in the field of experimenting and learning how we can engage meaningfully. And the point here is that we are more and more sharing. So there's never enough engagement because it's almost endless. So one of the tricks as well is that you do learn constantly from others, and so that means across local authority and CCG, but now the opportunity Merton and Wandsworth. There's also a lot that one can learn from what is written and researched, because often Merton is just like others. So I think the whole emphasis on being alert and awake to develop engagement is really promising, and I think we've moved on.
Thank you. David?
I know how much work goes into producing, the documents like this, so I accept that, and I know a lot of people will have put a lot of time into it. I guess the issue I've got, when you read this cold, it's really hard on some of this to really understand, well, what are we trying to do, what we're trying to get at, because not all of them have been assessed in terms of, so what is the impact? And some of the impact that's in the commissioning intentions is quite generalised. I was just looking at urgent and emergency care, impact, reductions in A&E attendances, LAS conveyances. It's very, I guess it's the point that Sarah is making. It is very high level. But then the problem is with that is then, provided the providers understand what's in here when you negotiate, that's fine. But I think for board members, and I guess also for members of the public, it's really hard to engage with this sort of stuff. It's partly because there's so much of it and it's so detailed. I think it's also around the sort of the language we're using of this. We might understand it here. I would challenge a lot of members of the public to really understand, well, what we're really trying to get at. So that's, in a sense, a general thing. I think what I'd be looking for is, post the commissioning round, that we're able to see what's that golden thread. So what did we say we were going to do now? What have we negotiated? And then being very, very clear in terms of benefits, impact, both in terms of the quality and the delivery of services, but also the financial impact on this. Now, I know we're not meant to have the financial impact as part of this in the detail, but I do think there is a piece of work to say, well, if we were to do this, which of these are the really big things? Which are the ones that are really going to give us that benefit in terms of improved services for the population, hitting the health inequalities, and also delivering the money? And you can't see that from this. And I accept that we're probably not meant to. But I'd like to know that has been done somewhere, and at least we could have that conversation. Otherwise, it just feels a bit disconnected from the other stuff we're doing. So I say I don't mean to be critical. I was going to say I know how much work goes into this, but there are some things that we need to, as a board, really be able to join some of this up. Yeah.
Yes. So this is here for discussion and to note exactly, because it's at a point in development, as you say. I would hope that you can see, so that's why I've been developing the plans on a page to articulate how our vision tracks through to the need and the types of work we're doing and where we might see the impact. I'm hoping that this starts to give a sense for the scale of change that will be required. So to take an example of, say, planned care, there's a reference in here to significant redesign of outpatient services with St George's Hospital in the context of our financial challenge. Now, I think what you're talking about is how we link this in with the operating plan later in the year, and how we see how these plans link into our assumptions around the impact on activity flowing into local hospitals, investment in the community, and so on and so forth. And you're also right to say some of this might drop out in that work, because it may be that in the final analysis we don't feel it's all value for money. Also, some things may get added in as we continue to discuss them. So it's useful steer, and I can continue to work on the narrative. It'd be useful maybe outside to pick up with colleagues if you've got some ideas as how it could be crafted differently.
I mean, Josh, presumably there's some sort of version of this that's being used for the engagement events that must be higher level and pictorial and describe what our strategic aims are in doing this?
Yeah. A number of versions for different audiences, yes.
Yeah. So maybe even though this isn't specifically for the consumption for members of the public, there might be something about having a bit of that at the start to set the context for a lot of the detail that follows, as well as then picking up your point about, okay, so how do you measure this?
Absolutely, Andrew. So in a sense that I think as a board we need to keep coming back to. These are our strategic aims, and and we know we haven't got many of them. But then whatever we're doing, how does this stuff relate to that? So you can see that golden, the golden thread, where you can see how one thing relates to the other, and then we're able to then say, well, we know if we do that, these are the benefits we're looking for. And then when we start to measure it, are we achieving it? Yes or no? Now, I know it's very easy to say that. It's harder to do, and I accept that. I guess we just need to try and work our way through that. Yeah. I'm happy to talk to Josh outside.
I think in that case as well, I'd also say, so we have a sort of vision statement for the Merton Health and Care Together programme, which is on the third slide of the slide deck. That essentially, I think the golden thread through all of this is integration and supporting well-being and mental health, and to do that at scale for the greatest number of people. What I would hope to say that our operating plan and associated savings programme would look like next year is you'll be able to see how we've invested in those things in order to drive impact elsewhere in the system, which is also leads on from that being the vast majority of what's in our current plan this year. So thank you for the feedback. We'll continue to work on it.
Sarah?
So the bit that I found quite helpful actually is in the slide deck, is when we get to the start well, live well, age well sections. And I think, taking on board what David has said, I think that where we've said the likely impact, it's about how do we quantify and measure that and take that forward and report back to the governing body. Because I think we would all agree with some of the things that we're doing here. The issue is how can we then evidence that that they've had the impact that we want. And I think the benefits realisation would be very, very helpful. But what I thought was very good about this and is reflected in many of the governing bodies is the fact that we're pulling this together as kind of formal commissioning intentions to providers across South West London, which we've done, but that they are that all of the commissioning intentions are supported by a very clear strategic plan for each local area. So for Merton being the Merton Health and Care Plan here, and I think that really helps us to kind of keep the direction focused on the local and ensuring that we get to the right outcomes. But taking on board David's comments, I think it might be how do we flesh out the likely impact part of this and make sure that the golden thread is through there, and then how do we actually report that back.
Casey.
So it's building on that really. I just wonder in the slide pack itself, given it's going to be used as an engagement tool, whether there's something about setting out the challenges in a little bit more detail as well. So there's a slide in here that talks about the quality, performance and financial context and talks about challenges at St George's and at the Mental Health Trust. I think it might be quite helpful to set out some of the primary care challenges there in terms of workforce and demand and funding and those sorts of things. Again, just so that it's there as the context piece really to help inform the discussion that you have with patients, that actually it's not just as easy as kind of we can do a lot of stuff better in primary care, that there are some really significant things we need to overcome, and that's what a lot of these work streams that are primary care focused are actually going to drive towards, I suppose.
Yes, agreed. Yes. That'd be any information you can give me would be great.
Are there any other comments or questions? No? Good. Okay, I mean, that was for discussion. You've got offers of some help outside of the meeting to develop some of the bits.
Yeah.
And it'll be interesting to see how it develops when we've done the engagement as well, and see how that does help shape things. But good job. Okay. That takes us then back to mental health services. So we've done section 7. We're going to go back to section 6, and this is our key area of focus for the board meeting today. Is mental health, and Patrice, our commissioning manager, is going to come and present.
Whilst Patrice is making himself comfortable, I'll just introduce the item a little bit, if that's okay. So we haven't, I don't think as long as I've been here the past year, had focus items in this way, the governing body. So I guess obviously the bulk of the detail of comments, I imagine, is going to be about mental health, and that's absolutely right. But it would also be good to get a steer, really, for me about the format, the level of detail, that sort of thing, for when we have future items of this type. This is first attempt. I think it's a pretty good balance, actually, between the level of detail and being able to provide a strategic overview to the board. But any comments on those two sides would be really good. So probably just with that, hand over to Patrice.
Okay. Thank you. Good afternoon. So we've prepared a paper for you which covers quite a lot of detail, well, provides some information on adult mental health services and some plans for child and adolescent, or CAMS mental health, CAMS children's mental health services for children. I'm not sure whether it's useful for me to recite the paper in detail, or whether it's better for me to pick out some highlights from the paper and then leave it open for you to question me. The first section starts with a picture of need. By far the biggest single group of people with need are people with common mental health problems or neuroses. We've also got...
Patrice, just to respond to your question, I'm very happy for you to go through section by section. Because this is an area of focus, I think it's fine to give it some attention. So if you want to go through each section, just pull out some of the key points. That's really welcome.
Thank you. That's really helpful. Thank you. Right. So we've got a small proportion of people with personality disorders. I think our biggest single... So one of the problems... So this table that I've given you, table 1, which gives the working age adults prevalence rates or numbers, incidents of people with mental illness. I think certainly for psychosis, which is not one of the psychotic disorders, I think if we compare this with activity in the Mental Health Trust, we'd find that this actually understates things. But this is based on our local population, and it applies like an algorithm to the number of people in the borough. So I think it's just under, I can't remember what the ratio is. But anyway, I think the main point to make is although this is valid data, it probably underestimates what our actual incidents of what our Mental Health Trust is actually seeing. The overview of funding, we are spending in Merton just over 26 million on mental health services. The bulk of the spend, or the planned spend for this year, is with the South West London St George's Mental Health Trust. We also spend a significant amount on what we call placements. So it's just over £4 million in the budget this year on these are bespoke care packages for people with complex mental health needs, who more often than not, they go through the secondary service, they come out and they still have a level of need which needs to be met by a hospital or a residential care home. Right. Okay, my machine's stuck. Sorry. Thank you. Sorry.
Don't worry, I had if it's reassuring to you at all, Patrice, I had the same issue and I had to switch to paper, so it's not you.
We're going very low tech.
Yeah. Thank you. That's really kind of you as well. Thank you. Right. So we our biggest, like I said before, biggest single cohort of mental health need is with people with common mental health problems. We spend just over just over £1.5 million committed to improving access to psychological therapy services. So those are IAP services, are services which specialise in treating people with common mental health problems. I think James Blythe described it as our IAP performance as our biggest single reputational risk for the local delivery unit. So that's Merton IAPT. I hope it's not the one thing that distinguishes my time with the CCG. So there's a couple of, I've talked about IAPT in the past. There's a graph here which shows over time how much we've missed the access target. So the access target for 15% is the red line. So we ought to be treating around 15% of the people in the borough with a common mental health problem. And apart from a couple of happy months, we've generally failed to meet that target. And I can talk to you in the second part of this discussion about how we hope to address that. We've also, in recent years, we've had a couple of demand and capacity reviews which are focused on the secondary mental health service. One which was published in 2016, focused on inpatient services, and a more recent one in which was published in 2018, focused on community mental health services. Okay, so the 2016 report on inpatient services it related to a crisis we had and probably still have in acute psychiatric inpatient beds. At the time, the report was published shortly after I joined, or shortly before I joined. I think in the year preceding the publication, the report showed that we were using just about 170 beds, or the equivalent of 170 beds, some of them within the trust, a lot of them in the private sector. We have in South West London St George's an estates modernisation plan which predicts us going down to 134 beds. So we needed a plan to contain that overactivity. I guess we're halfway through implementing that plan. We've made significant investments in the mental health urgent care pathway, and a couple of the things that we've got as a result of that is a crisis cafe, street triage service, and what's called the psychiatric decision unit, which is a specialist mental health service based at Springfield, which is designed in part to take people from accident and emergency to a mental health care setting so they can have a prolonged and more benign assessment rather than doing a rush piece of work in accident and emergency. I think the first review pointed out that there were things that we probably needed to do in community mental health services to support the reduction in our reliance on acute inpatient beds. And I think that first review didn't really give us a route map for addressing that. But we have had a more recent review, as I said, from an organisation called PPL, which was published in spring of this year, I think, which looked at, which gave us some results, I think, on community mental health services. For Merton, I've on page, I'm sorry, it's not numbered. In the table, in the document I prepared, figure 2 has a traffic light grid of the, or a RAG rated grid of the services, the community mental health services, which the PPL review looked at. I probably mark as someone who looks at things as half empty rather than half full, but even so, we've got just one green, which is our mental health and learning disabilities team. The other services are showing some signs of stress. The amber ones, I should say, in the written report from PPL, they said demand and capacity was matched, but then there are some footnotes about which suggested to us that actually, although things look fine on the surface, there's probably cause for looking below the surface to see if there are actually, if the trust is managing things in a way which is probably not conducive with what we want for patient care. And the final section of this paper looks at child and adolescent mental health services, which is an area which I'm no longer responsible for, but basically it seems as though they're doing really well, far better than I am. I think they're the only only one of the 5 CCG districts which is doing something around. Sorry, what's the thing that they've got?
So the trailblazer.
They're a trailblazer,
which
yeah.
we'll come to later.
Yeah. Okay. So I'm not doing that. So I went through that very quickly, maybe too quickly, but I'm happy to.
We run through the elements of the paper around sort of our thinking for next year.
Okay, sure.
Thank you.
Okay. So you've added this for me.
Sorry?
Did you add this for me?
No, you go for it.
Okay, thank you. All right, so the big plan for next year is to improve our primary mental health care services, and so we are planning significant investment in what at the moment I'm calling Merton Primary Mental Health Care Services. It will incorporate 3 new services, a wellbeing service, an expanded IAP service, and something we're calling primary care recovery. I think this is an important service development because at the moment in Merton we've got nothing in primary care which arrests the progress of anyone who feels mentally unwell. We've got nothing which arrests their progress towards secondary mental health services. So at the moment we've got a situation, particularly for people with severe mental illnesses or the symptoms of severe mental illness, whereby they are unsupported until the point that they meet the threshold for secondary services. We also, as I've already said, have a problem with our IAP service, so we are investing in IAP to make sure that we have a service which is of the right size and the right funding per capita, and also it needs to change the way it works. So there's a focus required under the 5-year forward view for mental health on people with long-term conditions. So the IAP service will need to work very closely, hand in hand with acute providers to make sure that people with long-term conditions actually have access to psychological therapies, which will help with ultimately will help reduce their health service utilisation. Right, so at the bottom of the scale, we've got a mental wellbeing service. This is the first treader on our step model of care, which is in this document is down as figure 3. The wellbeing service will be open access. It should have skills in working with people across the range from severe mental illness to common mental health problems. It's not necessarily a clinical service, but it should be of therapeutic benefit to the individuals who engage with it. It should provide them with support and links to other community assets which might help them develop or maintain their recovery from mental illness. And it should also have an interaction, if you like, with the primary care recovery service, which I'll talk about in a minute. Actually, I can talk about it now. So the primary care recovery service is the top of the treader, the top step on or the green step in the diagram. This service needs to work alongside professionals in primary care. It's not intended to take over the work that GPs do. I think the stats are that 90% of people with mental health problems who need support receive that support from their GP. This service is intended to work alongside GPs in that context. I think one of the things it could usefully do is support people who are discharged from secondary mental health care so that they continue to receive support from the right type of professional in the right type of areas, certainly medication management and understanding how your meds are supposed to work, encouraging people to take it, and also to work alongside GPs in supporting people with comorbid physical health problems. I think the figures are around 46% of people with chronic mental illness also have a long-term condition, a long-term physical health condition. So I think what will be helpful is if this primary care recovery service can also help the client to understand their need to engage with the GP, to work with the GP in other parts of the acute care pathway to make sure that their physical health is supported and met. I think one of the things that they could do, for example, is give advice around weight management. Some of the medications for people who are who have chronic mental health problems actually give rise to weight gain. So I'm hoping that this service, if it works well, would help with minor problems like that, which will mean that the risks of people dying early in the longer term will be reduced from physical health problems. So I think one of the questions that came up last time was how we arrived at this service model. We have spent quite a while thinking about this. I think we in December 2016 and December 2017, we looked in detail through the Equality and Diversity Scheme. So the jargon we used was EDS2, but we held a couple of workshops which looked at two talking therapy services which we provide in Merton. These were public events where people were invited to, in the context of equality of access, they were invited to look at a couple of services. In 2016, it was the Complex Depression and Anxiety Service, and in December 2017, it was the IAP service. So although the focus was on equality and diversity, I think we got a lot of feedback about those two services in general. I won't pretend to be an original thinker in this particular service model. We are attempting to emulate the Sutton Uplift model in many ways. So we went out for a period of public engagement between May and July of this year, where we talked about the service model, what we hope to achieve, and we got quite a lot of feedback. So the first event we did was the patient engagement group. We had a specific event locally in Merton. I can't remember the venue. Vestry Hall, thank you very much. And then we also did a session with Merton carers, a session with a local service user group called Focus for One. We also gave a similar presentation at Merton Mental Health Forum. This whole piece of work is being overseen by another committee which was set up recently called the Merton Programme Delivery Group. So that group, which has got user, carer and provider representation on it, has been acting as like a project management group for this. We have been careful, however, to make sure that when we are talking in detail about service specifications, for example, that the providers are excused from the room, because there are providers on that group who would probably be interested in bidding for the service. I feel I've said quite a lot and probably not enough, but maybe I should stop now and invite some questions.
I'm going to go first. Thank you, Patrice. I thought that was really helpful. It's exactly the sort of thing we've wanted to see, to give us an overview of what's going on with mental health and to understand the context and where some of the challenges are. My question before I open it up is, given what you showed us in the chart that had the ambers and reds on it, how confident are we that the changes that are being proposed in terms of developing the services and particularly focusing more on the primary care end is going to have a positive impact on the chart, which is essentially the demand capacity mismatch in secondary care?
Yeah.
Do we feel it's going to be enough?
I wish it were a silver bullet, but it's not. It should do a couple of things. So one of the things which both reviews pointed out was that our assessment service is not big enough. There are many cases where the service standards that we've set for responding to a referral are missed. So the business case that we've got for the primary care service does actually address that directly. I'm also hoping that if the service is effective, it should do two things. It should reduce the number of referrals into secondary services, so that in itself should help with those failures, if you like, in the assessment service in secondary care. But also, hopefully, if we've got fewer referrals, we should have fewer people going into the service as well, which should also help with the caseload or the demand of people coming from people in the service. The primary care recovery element of the service also should act as a way of pulling people out of the service, out of secondary care. So it should, if I contract manage it effectively, it should actually be a way for the secondary mental health service to say, well, these people are ready for discharge, we can move them out, and it should hopefully move them out for longer, so that the revolving door, the periods of revolving in and out of secondary care are reduced because they've got this primary care recovery to support them. So,
okay, thanks.
Can I add something to that? So I think what the review was really helpful was identifying where there are areas where on the face of it demand seemed to outstrip supply. This was a review done across South West London, and one of the things it also identified was that often the operational service model for some of these services that on the face of it should be the same is actually very different when you look borough to borough. And so not all of the answer around helping the demand meet the capacity is going to be around only additional investment. So there are certain areas in South West London that rely more on group approaches, for example, which means they are getting more out of their resources and so therefore are managing the demand more effectively than maybe some of the services in Merton. So we have to learn from it's a good example of where learning via our colleagues via the Mental Health Network and the STP is a really good thing. The other thing I'd say is that I think what this does is it gives us a guide. So back to the points before around the golden thread and the impact of this work is Patrice is right. This is not something that gets solved overnight, but it does give us a direction, and we are working very hard in our work around mental health commissioning to make sure that we can quantify the impact of investments in these areas, because in many places where investments have been made, that's not all that loop hasn't always been quite closed on what's the impact been in that investment. It tells a particular story. It's where we want to focus, but we'll look to quantify that for the board.
So let me just ask a follow-up question on the issue of investment. So I think what you're describing is a significant enhancement to what we currently have. I believe that you're looking at investing significantly more in IAPT to increase capacity in that service. I'm assuming there is an investment in a primary care recovery team or service. What about, because this is a question that Claire raised, what are we doing in terms of mental well-being? So we're assuming that in signposting we are going to send a lot more activity to the voluntary sector. So is there a process to I guess monitor that and to make sure that those services have capacity and appropriate resource to do the job? And I guess the other question related to that is around primary care recovery. If we're expecting more patients to be dealt with in a primary care setting, okay, we invest in a primary care recovery team to support general practice, but I'm assuming we might see greater activity or a greater number of these patients being held by general practice, and do we think there's going to be a resource implication there? It was quite a broad-ranging question, but
Okay.
all around the issue of resourcing.
Okay, so right. So the business case is built on largely on what I think I can see. The three new services, or will be within the primary care model for Merton, will be the wellbeing, the IAPT, and the primary care recovery. The wellbeing bit. So the way we intend to procure this is through a lead provider, which may well be an NHS organisation. We don't think that an NHS organisation will have the expertise to meet all elements of the spec of the specifications. In particular, the wellbeing elements, we would expect to see a voluntary sector organisation or more doing that work. So some of it will be contained within. Some of the additional work, if you like, will be contained within that work, within that tier. But I do think it's important that if someone with a mental health problem is going to be fully integrated within society, what I expect that wellbeing service to do is to help them to make those links. So I'm hoping that they won't be sending people who are burdensome to the other parts of the voluntary sector. I'm hoping they will help someone who might feel a little bit closed and reticent about making links with, a local football club, that this wellbeing service will help them to make that transfer and will also help facilitate their receipt into that service by the community asset, if I can put it that way. Right, so the bit which is I'm going to struggle with, and maybe Josh will help me out, is I haven't quantified what this will look like for in terms of additional work for GPs. I think most of the work, as I said, for people with severe with mental health problems is done in primary care anyway. What I'm hoping this service, the primary care recovery bit, in particular will be a support to GPs doing that work. But I guess we will see whether we do actually see more. Well, I've said we should expect to see the burden on secondary services reducing. Whether that's because we're just introducing an efficiency into the system, or whether it's because we're actually seeing more people going through the system, I haven't been able to work that out yet. I think we'll base that on what we see once the service starts.
So to add to that, I think so as everything this point of the year, we're in a point of development of the case. We have some learning from other areas relatively locally around mental health support within primary care, and I think there are two sides to that. A lot of it can be very supportive to the demands on primary care, where there may be an underlying mental health issue that at the moment services aren't quite there to address or support, and there may also be other pressures in terms of working within that new pathway. That's then for the commissioning and the primary care commissioning directorate to work through in the business case in the round.
Okay, thank you. Right, I'm going to open it up. I know I've got a question or comment from Andrew. No, oh, did I? Sorry. Dagmar and Tim. John and Sarah. Should we go around it? And David, do you want to all say what you want to say and ask you a question? And rather than getting Patrice and Josh to respond to each one individually, let's go around, collect them, and then we'll come to you for a comprehensive, holistic response. But let's start with David, and then I can go round in order.
Right, so can I pick up on the money one first then? So, and this might be a question for Neil, but if I look at the spending, so that 25.5 million, there isn't anything in here which says to me this is how we benchmark. So what is that level of spend? So the first question is, how do we benchmark as a CCG compared to our peer group? First question. The second one then leads from that is clearly the demands are going up, population's changing, the needs are going up of the population are changing as well. So it would suggest over a period of time, whatever happens, however we benchmark, we have to increase our level of funding. There is nothing in here which says, and this is what that amount of money is, and if that, and therefore, as that is a priority of the CCG, where do we then start to get that money from? And I think we've got to be just quite explicit, because there's no sense in this. What are we saying? Is it going to go 1%, and therefore we won't bother, or is it 10%, where we might? And I think we just need to be as clear as we can be. I'm not saying this isn't perfect science, but we've got to have some sort of sense of, what does it go up by? The other one, again, it's linked within here. And when I looked at that the table 2 is quite revealing. The amount of money that's spent on mental health placements and non-contracted activity. So it would suggest there is some opportunity, because we aren't the only CCG where this is happening, some opportunity to develop services locally in order to actually deal with that sort of resource. So I think, those are really my questions around the money. So I'll stop there, and then I'll let others come in.
Okay, if I just add a little bit, first of all, many things. It's helpful to have all the information in one place. I wanted to reflect a little bit more on the well-being part, because as David alluded to, in a frugal context we are working in, I would like to understand a little bit better how we make more of the assets that are existing, rather than thinking everything requires medicalisation and a new service response. And we have already got quite a good model emerging around the social prescribing, which is basically just a connecting model rather than creating new services. So exploring that and learning on that. And then in the same vein, clearly mental health requires a lot of face-to-face. Loneliness is one of the driver of our mental health issues, but digital looms highly, and there are some really evidence-based programs. So where does digital come in our toolkit for the lower end of the need?
Thank you. Sarah?
I wondered if you'd bear with me, Mike, because I wanted to make 2 comments that I think maybe the board would be interested in, and then 1 question. So the 2 comments were around, actually they were around what you were talking about, David, which was around specialist placements and out-of-area placements. And I just wanted you to make you aware that there is now a work going on across what they call the South London Partnership, which is South West London St George's, South London and Maudsley, and Oxley's, which is the whole of the South West London mental health provider network, to look at, particularly for specialised commissioning for out-of-area placements, to bring placements back into South West London and to make efficiencies on that. And what we are, and they've been very successful in that so far, and they intend to continue to do that on the basis that the money is then, any savings are reinvested into mental health, but into different new models. And I think we would like to work across South West London on a similar type model for our out-of-area placements with the Mental Health Trust, and we are in discussions around how we might do that. So I wanted to put that out there, and then it's about saying, and then how do we reinvest, because what we're not doing is taking money out of mental health. What we are doing is trying to reinvest in the more appropriate models. So that was the first thing. Second was, I did want to just highlight the fact that we have been successful with the perinatal mental health funding, which has been a huge bonus to South West London. So as well as the children and young people mental health, which we hope we're going to be successful in, we are sure we're going to be successful in, I hope, she says with the hope at the end, but perinatal mental health, major issue nationally, and we have been successful in South West London in gaining lots of additional funding, and I think this is a really positive thing for South West London, and I think, I just wanted to highlight that. My question was actually around bed numbers, because when you quoted the numbers of beds in South West London St George's and the volumes that would need to be reduced as part of the ongoing business plan, I didn't recognise those numbers, and I just quickly went back to my papers that I have from the Mental Health Trust when we were talking about acute beds. I just wanted to check, they're probably the right numbers, but they may not be the ones I'm understanding, because The message that I've heard from the Trust recently is that through the work that they've done on engagement and the ongoing work that they've reassessed around their business case, although they'd originally reduced the number of beds, they've now increased them back up again, and there's actually the reduction in numbers of beds through the OBC is quite minimal. That does still mean we need to change the model of care, but I wouldn't want the message going out that we've got this massive reduction in beds, and I just wanted to check that before and make sure we cleared that up. I've actually got the reduction in beds across the whole of South West London as being only actually a handful, is less than a ward. So I just wanted to check that before we kind of quote numbers out there.
Was that your question?
Yeah. That was
okay.
my question.
Karen.
I'd just like to make an observation about the crisis cafe, which as a GP I've had very good individual feedback from patients about. I just wonder whether there was actually any data yet to see how effective that's been and whether that has had an impact on admission rates, for instance. That was the first thing. The second thing was about the primary care part of the service. I think it needs to be embedded in practices. It shouldn't run in parallel. It should be part of the primary care offering. Otherwise, my concern would be that there may be duplication. And ideally, if there could be record sharing as well, the holy grail of record sharing, I think that would also help everybody.
Sorry, there's a whole load of thoughts came in my head. The first was about David, about benchmarking. Danger of benchmarking is you benchmark yourself against a load of underinvesting CCGs, then we may look good next to an underinvesting CCG. I'd almost, if I was going to benchmark, want to benchmark against the very best in the system to then see how we compete. I think if you're going to look at the money side of things and then work out what you can afford to deliver. It was following on from Dagmar's. There's a networking thing here. We're spending a lot of time as a GP managing life. Life is jobs, life is exams, relationships, unemployment, bereavements, breakups, and I don't think I have all the skills to manage those. I can communicate, I can talk to people, but it's often not the right person to manage a lot of those skills. And we saw it when we went to the Bromley by Bow setup, when we did our visit there, about how they approached employment, helping people with CVs, getting jobs, getting back into engaging in life. And those are all the sorts of things that really help mental health. So I think it follows on from Dagmar's point of how do we network these people with the right services to the skill sets that will help them accomplish their own little goals and things that are causing their own anxieties, because we end up medicalising life, and that's the bit that I'm sure Andrew and Karen spend a lot of time seeing patients managing their normal goings on, and what we might be better looking at is then the longer term proactive engagement in our seriously mentally unwell patients and looking after, because their life expectancy is less than a patient who doesn't have mental health problems, and therefore how could we be a little bit more proactive in managing their medical needs, screening, their uptake, smoking, obesity, all the things that probably have an impact on them. I think that was it.
Thank you. Neil, was yours a response more than a question?
Yes, and I did have a question within it, but I'll do my response.
Okay, fine. John.
Thank you. I guess general reflection on all the discussion, and thank you, Patrice, for the summary, is the issue of workforce, because so many of those access and waiting time standards and the capacity issues that you've raised relate to the availability of workforce to fill those various rotas, be it in the relatively at the shallower end of this around the psychological therapies, or at the very specialist end around some of those very high cost placements. And I think the workforce challenge is across the board. It's a general point really around perhaps South London Partnership or others around what more we can do around workforce development, attracting that workforce, retaining it, because in a rising tide of demand, whatever levels of investment we're now adjusting to, and however we benchmark and whatever further work we do, I guess there's a real need for the workforce to fill those various rotas and establishments. And I'm not sure, given the move to have more people come back to South West London, the expansion we talked about recently in terms of education settings, etc., just how easy it will be for that workforce to be found and secured.
Okay. And then just final point, would be helpful if we just touched on children and young people as well. So if you wanted to just put...
You might want to do that.
Okay.
I can, but given you're right in the middle of it, if you wanted to.
Okay. So I can tell you about children and young people's mental health. Obviously the work I'm doing is more focused across South West London and is on the work we've been focusing on up to now was driven by the rising incidence of self-harm in our children and young people, particularly in teenage girls, seeing that go up massively. That led us to look for how we most effectively address the problem. We've decided to really invest in well-being and resilience in our children and young people, particularly focused around schools. So the elements of that are support for teachers, helping them to recognise and respond to mental health, general education and support for young people, and then much more targeted intervention in schools for those who are at higher risk or have emerging problems. As part of that, also looking at support for parents and recognising that there's a whole range of different well-being services that will help young people deal with levels of distress and stress that they're suffering that it's very difficult for young people to access. So one of the elements of the work is to actually map that borough by borough and create an easy way of both young people but also people who are supporting young people accessing those services. We've also agreed that with the single point of access for children, that it's not as accessible as it could be, and it often relies on a professional referring the young person. And what we'd like to look at is really broadening it, like some areas have, so that young people themselves can have that as a first place to go to, and that the single point of access isn't just a filter to get people into tier 3 mental health services or to redirect them to children's counselling, but rather can direct them to the range of services, including tier 1 wellbeing services, so to make that really a much more effective place to go. We've worked very closely with schools, and so we've developed in each borough, we've identified a cluster of schools who are going to pilot what we're calling the whole school approach, so that we can learn from that and use that as a forum to engage some of the young people and teachers in designing what will work for them, and then we will be able to roll that out more broadly. Having already agreed this programme of work, we've now been given the opportunity to bid for the Trailblazer Green Paper funding, which asks you to deliver 3 specific developments. The first one being a designated lead in each school. Now, we'd already planned that as part of the work we were doing, so that's fairly straightforward. I think the challenge is making sure that it's not just a name, but it's actually someone who really is taking a lead role and is equipped and supported to do that. The second element of the Green Paper is mental health support teams, so looking at the CAMS service and thinking about how do we reorientate that around schools and how do we significantly expand the workforce. So it's developing mental health support teams that work with clusters of schools or networks of schools and really kind of reach into that context to support young people and pick them up before they get to the point where they need to go into the higher resource tier 3 services. So we're planning on doing that. One of the key issues, as you mentioned, is workforce, but one of the reasons we've been allowed to apply is because we already have links in with King's and UCL, and they're named partners for training what are called children's wellbeing practitioners. So the idea is that the mental health support teams, although they are supervised by people from the CAMS service, a lot of the workforce will be lower level, what we call children's wellbeing practitioners, and it's a year-long training program, but they will be doing some work on the job, and most of the funding that comes with the Green Paper Trailblazer process is linked to paying for that workforce. The third bit is there is a requirement to reduce referral to treatment times for children and young people for CAMS to 4 weeks, which is quite a challenge. So in Merton, I think at the moment it's about 11 weeks, and we will be that will be quite a challenge to make that happen, and I think that will probably be the most difficult bit of it. So at the moment we're looking to put in a bid across Merton, Sutton and Wandsworth, because we're the ones who passed the threshold criteria to allow us to do that. We will take the learning from this and we will look to rapidly roll it out across South West London. If we don't get the Trailblazer funding, we're going to continue to do all the stuff I mentioned at the start, and we'll see what bits of the Green Paper recommendations we can do anyway, but if we're successful, it would be a real step change in what we can offer. That's that bit of it. What I don't have, the bit I can't really give you a proper update on is the current nuts and bolts CAMs. What I do know is that, because we've been looking at as part of this project, is the Children and Young People's Counselling Services in Merton, that we are going out to procurement on that, and we're going to increase the investment in that so that we can increase capacity.
So just to add to that, so the work that Andrew's described actually pulls together a number of strands of the work that appeared in our CAMS transformation plan, which came to the governing body about 9 months ago. There's also elements within that plan to look at ongoing development of services around autism and ADHD, making sure that assessment pathways are clear and consistent and as quick as possible, and support people both pre and post any a diagnosis and support required. There's also work going on across South West London to develop eating disorder services, which forms part of a developing South West London programme of work around CAMS. I just wanted to raise the CAMS transformation plan, because that will need to come to a future governing body over the next few months. It is due a refresh, as I think we briefed the board last year, and it will also go to the Health and Wellbeing Board for sign-off, and is being overseen by the CAMS Partnership Board with the local authority and via the Children's Schools and Family Partnership as well. Thank you.
So, Josh and Patrice, would you like to give a response to the various questions and issues that are raised?
Workforce one, if that's okay, on the South London.
So Sarah would like to input on workforce. Neil would like to input on finance. Okay, you have a go, and then we can feed in the comments from the subject matter specialist.
Shall I kick off? So if I'll cover, I think I'll cover David's questions and then hand over to Patrice for some of the description around the wellbeing services and some of the implications. So, in terms of how do we benchmark compared to our peer group, so that story is different depending on whether you're talking about adults or children's mental health. In terms of children's mental health, we're sort of middle of the pack against our peers. For adults mental health, we benchmark relatively poorly against other CCGs, both in London and similarly. However, that is exactly why we're seeking to invest additional amounts in this area. Part of that is due to demographic differences between Merton and other areas of London in particular, but it just also reflects the fact that we haven't invested as heavily as in this area in the past as we would like to going forward. In terms of the point around sort of the underlying growth in the area, essentially attached to demographics, which I think was what's the underlying demand growth. I don't have that to hand. Patrice may do, but that's really good feedback for future focus areas, that we almost present a bit of the what if we did nothing option, what would that look like over time. That's really good feedback, thank you. And on the placements point, Sarah answered that previously. We have made a commitment up front that as much of the money that we can free up in that way get to reinvest into community mental health to help ease some of the pressures that we've talked about elsewhere. Patrice, do you want to talk about the wellbeing questions from Dagmar?
Sure. So within the business case for the primary healthcare model, there is one slither of predictive funding, if you like. So the IAP service is really quite binary. It's really easy to calculate how many staff you need and how productive they're going to be. So within that, we have plotted an increase in investment specific to that service. But as Josh says, we haven't done that for other parts of for the system as a whole. The wellbeing service and making sure we make use of existing assets. So that I think is what we're trying to do with the wellbeing service. I think there are a number of services which are specialist and not so specialist, but which could be useful to people who are struggling with isolation or other things which are probably giving rise to poor mental health, or certainly poor mental well-being. One of the things that came out of some of the earlier, I won't call them engagement meetings, but some of the discussions that I had with people who live on the patch and who have experience of mental health services is that they come out of services feeling that they've got no support at all. And having had that cushion of support, whether it's in IAPT or in secondary mental health services, they feel quite at a loss coming out and having not only no support, but no idea about how to go about getting that support. So I hope that's one of the things which this wellbeing service will do. I think part of its role will be very much like social prescribing, but it needs to be sensitive to people who have a history of mental illness, who don't always feel that they can go to generic services and get the kind of support and understanding and be listened to in the way in which I expect this service to do. And the other thing that I've talked about with colleagues in public health, I think at the moment there's a collaborative or a way for the voluntary sector and commissioners to speak about services, what they can do, what they offer, and how they might work together. What I will be requiring for this new provision is that I'm assuming that that collaborative will continue after you've completed your procurement. And what we've talked about with Barry is to make sure, Barry Causer in Public Health Merton, is to make sure that whatever comes up from our procurement in the wellbeing sphere, it participates in that collaborative, so that there is a way for that service to make sure that the community assets, if you like, are utilised as much as possible, so that we don't just think that the immediate reaction is if we see a gap, we go and spend more money. It's about making use of what we've got already. Right, so maybe it's my age, but I haven't given a lot of thought to digital programs in this procurement. I haven't specified that anywhere. But what I will say is that we held a provider day as well. And a couple of organisations which attended the provider day were digital providers of not just IAPT but also wellbeing services. So Big White Wall in particular has a presence in Wandsworth, and they will shortly on an interim basis have a presence in Merton as well. Obviously I can't predict what the outcome of the procurement would be, but certainly providers understand, and that the way the spec will be written, we will be looking for innovative ways of delivering services, and that is probably, although I could make it more explicit, that's probably a euphemism for making sure that they are efficient because of the way they deliver the service, and that will involve some digital provision as well. But I haven't thought of it more.
Can I just come to that point? Because I actually think the way that Patricia put that is actually really important. So we'll be looking for providers of services to demonstrate to us how the way that they provide this service meets the needs of the people in Merton. We're not just going to blanket say you must have this or that, etc., and just tick the box. So when we do the procurement, and I'm sure I'm really looking forward to, I'm going to be on the panel, and I think the last stage of it is the day before I go on leave, so I'll be going away very enthusiastic, hopefully. That's something we're really going to test. So if you have digital models, how does that work? Who's that going to identify? Who's that going to be good for? And who's it not going to be good for? And how are you also going to provide maybe more traditional types of services for other people as well? So I think whilst it isn't something that we're being very prescriptive about, we do want to see that reflected in the procurement.
Thank you. Right, so the bed numbers. Right, so my figures were historical. My apologies, I should have said that. So at the time the review was done, that was the problem that was faced with the 170 plus and 134. Of course, things have changed since then, and the bed numbers are different. So I should have made that clear. My apologies. Right, so we haven't. I think we've had one interim report about the Crisis Cafe from the Trust. So we're relying on all our analyticals to come, all the analysis of the Crisis Cafe will come through the Trust. We're not due a formal review until November, sometime this autumn. I think it's November. So at the moment, the feedback that we've had is that it's working well. They are having problems in counting or quantifying the impact, for example, on A&E. I think there are information governance rules which prevent them from looking at people who've gone to A&E and gone to the Crisis Cafe, or have a history of using A&E, and who have then used the Crisis Cafe and then no longer use A&E afterwards. I think alongside that, and I'm not sure that will report in November as well, the Trust is also looking to procure is not the right word. They were going to engage an academic organisation, a university, to do some qualitative work, so interviews with clients who actually use the Crisis Cafe, and ask them, have you been a frequent user of accident and emergency, for example, and having used this crisis cafe, do you see your use of A&E reducing, or do you think you'll use A&E less in future? So I'm not sure we'll be able to get that through objective data, but certainly there's a qualitative piece of work which will look at some of the other system benefits from the crisis cafe which we can't get from the data.
And just to build on that, just 'cause I'm reading the 9-month report that came out. So with a combination of that qualitative assessment and looking at the performance of the service over time, they've given what they present as a very conservative estimate of around 900 avoided A&E attendances due to the crisis cafes, around 100 a month at that point. Although some people have been referred on to A&E because when they present they actually do have needs that need addressing straight away. But actually that might have meant that was managed more positively. I think it is also, I would say that from a sort of a word of mouth qualitative perspective, people have been really impressed with the impact this has had on people's lives. We do think there's an element of unmet need that's been uncovered by these cafes as well, so it may not track through into actual reductions in some cases, but it's good that it's providing the service for people who've needed it so far.
Thanks. Right, so forgive my presumptuousness, but I have written the spec which advises or recommends or requires the providers to work embedded in primary care. There's another impact I haven't really quantified, but that's the expectation. I'm not sure that this service can be certainly, well, none of it can really be successfully delivered at arm's length from the GPs. It needs to be worked really well with GPs and with the acute care pathway. Okay, so the other bit which is not well thought through is definitely or well developed is the record sharing and the record keeping. And I'll have to think of so I can't remember what system you use in primary care in Merton, but it will be different from the data recording systems which I have to use, and probably which the provider of the primary care recovery element will use. We'll have to find a way of overcoming that, and I'm not sure precisely how that will be. I think that will have to be something which we do post contract award, so we're clear who the provider is and what system they're using. But that needs, I'll deal with that. And then I think Sarah was going to answer the questions about workforce.
Yeah, just so I did actually meet with the Chief Executive of the South London Partnership, who wanted to promote to me their annual review of what they've done and what they're doing going forwards. There is a document which is very short, which I've sent to Fraser to send around to everyone, but part of the work that they're doing is around workforce, and in particular around a nursing development programme, and that includes they're developing apprenticeships across South London, which they're hoping to increase the number of apprentices coming into mental health workforce across South London. They're launching a South London Partnership recruitment campaign to attract new staff into mental health services. They are working on a passport across South London so that so the staff can move around. They're putting in training and education, rotation placements. So they're doing, and there's lots more, but they're doing a huge amount of work to try and sort of train, recruit and keep staff within mental health services. So I thought that was very positive. The document that I've sent you is very short and quite helpful, and it also talks about their work on the forensic new models, CAMS new models, and their complex care. So it's just worth having a look at what they're trying to do across South London.
Thank you, Sarah. And Neil, did you want to come in on the finance?
It was probably just to be a bit more explicit about the source of funds, which is what I think David was alluding to. So in our financial plan for 1920, we've put the growth in our allocation, we've put that against mental health. The question I had, which because I don't know and I hadn't seen it, was what was the value of the investment that's being required? But I'm going to hazard a guess that it's going to be considerably more than that amount of money that we've got. So therefore, this is about looking at where can we recycle expenditure. That isn't just restricted to mental health, but that's the usual quandary that we've got around equip development. So at the moment, there is an absolute commitment. One of the areas we'll look to do is if we can find a way of restricting the demand into South West London St George's. That helps in terms of the contract negotiation, because then the pressure or the need to have to fund that contract means you can put more money elsewhere.
Sarah?
I was just going to say we do need to be careful about benchmarking against levels of investment. We are committed to investing in mental health and to the mental health investment standard. My experience is that actually what we do need to focus on is outcomes. Often you can have less investment and better outcomes, and what I wouldn't want to do is just to invest money for the sake of investing money. What we need to do is make sure that the outcomes that we are achieving are the right outcomes, and there's benchmarking to be done on investment, but there's also benchmarking to be done on the outcomes that we achieve for our local population, and I wouldn't want us to just do one or the other. We have to do both.
Thank you. So if I can just sum up, I thought that was an incredibly helpful session. I know we'd been thinking about whether we made sure that at board we did take more of a strategic focus and did some things in depth. I think I'm assuming people agree that was probably a helpful way of doing things. I'm looking at faces around the room to get a sense of that. I'm really glad we were able to spend a fair bit of time on this. It seems to me that there's been a number of really important points raised. Certainly in terms of the procurement, Patrice, there's clearly a fair bit of work to be done even after contract award in terms of shaping the service with the chosen provider. And I think I'm sensing you've got a number of offers of support with that if you do need help, and I think we're all collectively saying this is really important and we want to make sure it's very successful. So well done. It's exciting to hear what's being planned. We'd like to definitely support you to make sure that what comes out at the other end of the procurement process is really fit for purpose and really does shift things on. I guess my follow-up question to Josh really is, do we have in terms of a forward plan for the board and thinking about what items are coming up, do we have a process for agreeing what we're going to focus on at subsequent governing body meetings?
No, not yet. I think outside, if people would like to suggest areas of focus for future board meetings, that would be very helpful, and then we can build it into one of our regular one-to-ones planning for the board sessions, or we could bring it via our exec management team and look through how we plan.
Okay, so what I suggest, firstly, if people have further thoughts and comments they'd like to feed back to Patrice and Josh relating to the discussion we've had, please do that by email. If you've got thoughts about how we might structure the forward plan for the board and areas you think we should be focusing on, please email me. I will have a conversation with Josh and James about how we might do that in a structured way as well, rather than us just thinking about what's important, making sure that we are at future board meetings covering the full breadth of different services and areas that we're responsible for. Dagmar.
Yeah, I just wanted to ask, I thought the thematic approach, we wanted to have some feedback, so in principle, really, really helpful. We used to have the patient voice for a number of governing body boards, and then it didn't happen again. And I was wondering whether the thematic approach and the patient voice would lend themselves to complement. So starting a thematic approach with a little vignette of this is the lived experience might even further enhance the sort of experience.
I think that's really sensible. I completely agree we should do that. What we will need to do is think about how we structure the board agenda, because we did have 15 minutes set aside for this, and I knew it was going to take a lot longer, which it did. I don't want to bring things here and not do justice to them, so we need to just have a think about that. And on that note, we need to move on through the agenda because I am running really quite behind. So if we go on to, thank you very much, Patrice. If we go on to section 8, finance, so we've got the summary minutes of finance committees in common, and then we've got the month 4 finance report. Neil and David, how would you like to do this?
So very briefly, we've had two meetings. You've got the summarised minutes. There's also been a conversation of finance chairs with James Murray to talk about some of the broader issues across South West London. Just on the Merton position, so this is as at month 4, but the data really relates to month 3. So we're a couple of months now behind. What is pretty clear, as you'll see, I mean, what's the overall message from here, which is that there is some financial risk emerging. Probably it's no surprise to us, But it's it's really what then what's the result of that, and what are we going to do about it? So you particularly, Neil can pick up the detail. There's clearly some issues around acute demand. There's some issues around the QUIP programs as well. So what we said as a finance committee, certainly by the time we next meet, we'll have had at least another month's data, and we should be able to then get a better fix on where are we at, and then collectively what's the position across South West London, and how might we handle this collectively. And that's where we need to get to, and that's a conversation we'll pick up later this month at the next finance committee. I mean, you've got the detail, but I'll hand over to Neil to take you through some of that.
Okay, thanks, David. So I'll take it that you've gone through the report, and I'm not going to go in the detail that's in there, but I'll just pull out some of the key headlines. In terms of the finance scorecard, just to note that that we had to complete a finance and governance checklist, and this is a quarterly requirement now. The NHS England have asked us to do it. You might remember it previously called a financial control environment assessment, which was really just a self-assessment to ensure that as an organisation that we fully understand all the risks. It isn't just a finance return, it is a governance return as well, so it has to be owned by the organisation. In terms of moving on to the position, so you'll see that we are still reporting on plan, both year to date and forecast outturn, but there are a number of risks that are beginning to emerge in year. If we take acute first, cost pressures you can see at Epsom St Helier, Kingston and St George's. Around the St George's numbers, we are expecting that the QUIP will bite from Q2 onwards, so at the moment the early time of the year means that we can't really make any other assumptions than that, but that does represent quite a significant risk if those don't start to achieve, but at the moment we're assuming that they will. The other risk is around RTT, which we are not really seeing any inroads in terms of the numbers coming through, so the planned care activity is relatively flat, if anything is a little bit lower than we might have expected. So that's something that potentially could ramp up until maybe the winter period really kicks in. The CSU are pursuing a number of the areas of challenge with those providers, and given that most of the issues are around our South West London providers, we've hopefully got the teams on top of that and pursuing those challenges on our behalf. In terms of non-acute, so no real major issues around that. I think to note on mental health, there is still some investment that we haven't committed as yet. We are keeping some of that back, but that's available for spend as and when we need that. There is still some risk though around the continuing healthcare, so you'll note that I've mentioned this before. We've transitioned to a new provider in July. Now knowing how the new provider will work, they're going to be going through a lot of the activity and delving into some of the detail. So it could be that something comes out of the woodwork that we weren't expecting. At the moment, we've assumed a break-even position around that, but you'll note on the risk and mitigation sheet on slide 10 that we have said in our worst-case scenario that potentially could be anywhere up to £500,000, but that is very much guesswork at the moment. It could be that we can contain the problem within the budget we've got. Moving on to primary care, there isn't any particular issues around delegated commissioning, so we're able to contain things like the pay award that's come through within the budget that we've actually got. And in terms of prescribing, we've only got 2 months worth of data in here, so it is a little difficult, but again we're forecasting that we're on plan. I think to note this issue around the price issue, the category M drugs, so this is the prices for that are set by NHS England. They're due to kick in August, and apparently it's August and September only. and then after September they'll take a review on that. So at the moment we've not factored in, but again you'll see in the risk and mitigation table we have put what we believe the estimate is if those prices was to kick in from August onwards. In terms of the QIP, again we're showing a £750,000 underperformance against the original target. We do expect to be able to mitigate that through one-off, so this may be about unutilised accruals or other budget underspends. Clearly there are bigger risks within the QIP programme that if some of the plans that at the moment we're assuming are going to hit, mainly around acute, that could be more than that. And again, you'll see from the risk of mitigation some of the values that we've put in there. Other issues to note is that a practice transfer has happened. So there is a practice of transfer into Sutton. The expectation is that this will be cost neutral. We're working our way through the numbers. What we've agreed with Sutton is that we will keep communication channels open, so it won't be a final, because we don't know really from either party whether or not we've actually got the transfer right. What we haven't done is gone for a complete allocation-based transfer, which was what would normally happen. We've tried to match the costs and the allocation together, so there is some link between the two. So with best endeavours, we're trying to do a cost-neutral approach. I plan to bring to the next board the paper that sets that out in more detail. We still haven't quite agreed the numbers as yet, but I will bring that back, and it will obviously have gone through, and it has been through Finance Committee, a draft version, so the Finance Committee have seen that. To note, running costs all on track. And in terms of the financial analysis, the only bit to point out is still the issue that we've got around the payments of invoices. So it's disappointing that despite the actions that we've put in place, we're still not able to get that target up to the 95% minimum level. So we need to review the action plan and understand what some of those issues actually are, because it'd be very disappointing to miss that target, but the longer we leave it into the year, the harder that's going to be to recover. All of the other indicators are okay. So in terms of a summary of where we are, as you can see from the risk and mitigation table in slide 10, we've basically said if all the risks emerge as we've set out there, we're going to struggle to hit our target surplus. Now, whilst that can't be given the very early stage of the year, it's very difficult to say for certain, but I think what I'm trying to pull out there for people is that it's going to be incredibly tight if things start to move from where we are at the moment. And whilst that would deliver a break-even position and would just mean that we wouldn't have delivered the surplus, we've clearly got to keep moving towards achieving the overall South West London control total, which that 1.9 million surplus is a key part of it. So I'd like the governing body to note the risks and also to be assured that we are testing out this through the Finance Committee for the robustness, which hopefully David would be able to concur with. Okay. But I'm happy to take any questions from the detail in the paper.
Thank you. Are there any questions? I think you spelt it out quite well for us. It sounds like we're doing what we need to do at the moment to try and mitigate those risks, and you'll keep us updated.
Yes.
Thank you. Okay, let's go on then to section 9, which is quality and performance. So we've got the governing body performance report, and there's a quite helpful summary at the start which sets out what the highlights are. Is there anything particularly you want to pull out for us, John?
Thank you. There were 4 areas I wanted briefly to update the governing body on. The position with A&E, the ongoing position with RTT, cancer performance, and briefly, because Patrice already mentioned some of it, but the IAP position. So I just wanted to go through those 4 things, then take questions on any part of the report. The A&E position, as reported in previous governing bodies, had a strong start compared to certainly this time last year. And for April and May, the Trust overachieved against their agreed trajectory. That trajectory was slightly below the 95% standard, but was a recovery trajectory that was agreed with NHS Improvement. The most recent position for June and July dips slightly below, so for June, marginally underachieving now, back with the 95% target, and for July, performances remain very static at 93.28%. We continue to do a significant amount of work with the Trust around maintaining and further improving the A&E position. There's a 15-point plan which has been in place now for a number of months. About a third of that has been delivered. The remaining two-thirds remains ongoing. And all this is becoming tied up now in some very detailed winter planning, although winter is still a couple of months away. We're looking at what, based on last year's experience, what the likely deficits may be across the health economy, not just at St George's in terms of bed deficit, but across the health economy in terms of community services, primary care, social care, all the contributing organisations that deliver services across the winter and in times of severe stress for the health economy. So we continue that, and we continue to develop a model of what those services look like based on all the various business intelligence inputs we've got around attendances, access, waiting times, etc. Secondly, to update on RTT. So St George's are moving into the final phase of their RTT recovery and are beginning to focus on return to national reporting. NHS Improvement, NHSI have some very prescriptive recommendations around any organisation that stops reporting, that wants to recommence reporting. So St George's are working through at the moment a whole range of actions around the governance and accuracy of their various patient tracking lists and waiting times information that will support them in return to reporting. The decision ultimately is a trust decision, but does seek commissioner agreement. So we're working at the moment to agree what that assurance model looks like, to agree the window in which we think it's most likely that the trust will be in a credible place where all the waiting times issues are resolved and they can sustainably recommence reporting with the required degree of accuracy and sustain that going forward. Cancer has been, after a period of being above target across the vast majority of the standards, there's been some issues with 2-week waits and 2-week breast symptomatic waits. Again, we are now, with the very latest provisional August data, which isn't included because it remains draft and subject to further validation, coming out of that period of underperformance. The breast symptomatic in particular was linked to a lack of capacity within the service, with a number of people leaving the service, some sickness, and the non-availability of some regular locums that work in that service. Croydon Health Services provided some capacity during that period in June and July and the very first week of August, and now we are predicting that for the month of August that the 2-week wait position will be compliant with the national standard, and also the 2-week breast standard will be likely to be below the national standard, but that will be the last month it's below, and then recurrently above from September going forward. And finally, the IAP position. So Patrice already mentioned, and it's well known to this governing body, the significant issues over the last couple of years with the IAP provision. We are now bringing on stream some interim provision from September to March to work alongside the Ad Action Service, and myself and Julie from next week onwards are holding weekly operational review meetings with Ad Action where we go through the waiting list and understand in patient level detail the next steps for those people waiting for their first appointments or second and subsequent appointments. There is some positive news within the overall position. The Q2 position has improved significantly from the Q1 position. So again, this is draft position, but we're looking at the moment much better for the first 8 weeks of Q2 compared to the same, the first 8 weeks of Q1. And I think perhaps reached our limit in terms of what we could reasonably do as a commissioning organisation to help support. But I think going through a weekly operational review meeting means that we have every point of detail we could ever need. And back to the workforce issue, I think we'll have complete clarity on the relative demand and capacity of the service from now going forward. So I'll pause there, but happy to take questions on any part of the report.
So do we have particular questions for John on the performance report? Let me ask a question then, John. When we're looking at the A&E data, we're just seeing it for St George's at the moment in this report, are we? I'm assuming that the performance at other trusts is being monitored. Are we seeing that data for Merton patients across all our providers or not?
So at the moment, we're looking at it on provider level. There's been some recent issues with looking at aggregate position for Merton patients, regardless of where they attend. But that's something we've been trying to resolve with our CSU colleagues. But we certainly are monitoring across South West London.
So we have data for the providers. So each of the providers, and you should have the providers in there in a separate bit on A&E. What we can't do is, as you say, disaggregate it into how many Wandsworth patients is that then, or how many Merton patients have gone where. So what we now got is just provider level data. What I would say around A&E is actually there has been an improvement at St George's. We had a bit of a dip at Epsom St Helier, but that's come back up again now, so we're quite pleased with that, and that Kingston are actually delivering quite well on A&E as well. One of our big issue at the moment around A&E is at Croydon. That's the area where we've got some significant issues around performance around A&E, but the other providers are actually holding quite well and doing quite well on their performance.
What are we actually measured on though? Are we not measured on performance for our patients?
So we're measured on, well, we are supposed to be measured on performance for our patients, but at the moment we can't measure that. Yeah. But so we will be when we are assessed, and I think based on the fact that, and I don't know what the percentage is, but I would think that Merton's just missing the national target, because even actually Epsom St Helier is achieving over 95%. St George's isn't quite doing it, but they're very close, but because of the volume of patients is much smaller that go to Epsom St Helier from Merton, so therefore is probably just missing, would be my assessment of it. However, it's probably hitting over the trajectory we were expected to get, because although we're not meeting the national target, we had a trajectory to get back to the national target.
Tim?
John, just a quick thing about the breast cancer that sort of just fell off a cliff, didn't it, in that July. It's about our reactivity. Obviously, we're now here 2 months down the line, or a month and a half down the line, having a look at this. It's whether or not there is anything a bit more acute or finger on the pulsey that we can do at the time of something fairly significant like this that can then inform our intelligence and communications with our practices to maybe look at we've already had these discussions over the last couple of years about diverting to the other services we have surrounding us as we do, and we look at a number of providers. Is how reactive we can be to this data. I find from a strategic point of view us looking later, but is there anything or any heads up we get when they suddenly say, well, hang on, 3 of our consultants have left and we now can't manage a service? Should we react to that at the time?
So I think we did. I mean, I think within a few days of these problems emerging, we did. I think part of the issue with So we bring data to the governing body. We want it to be the signed off official data, and there's always a couple of months time lag. So certainly through internal CCG committees, IGQC, etc., we need to make sure we bring some unvalidated data there to make sure we can see emerging problems, with the caveat that remains draft.
Did we talk to primary care about this? I can't remember. I mean, and obviously it was some holidays and bits and pieces that may have been away, but did we have communications with practices just at this point of recognition then?
I need to look back at what, in terms of that specific question, what comms we had with primary care, but certainly the cancer commissioning team were aware back in end of May, beginning of June when this emerged, and George's began publishing their draft position ahead of the confirmed position for May, and the arrangements were fairly quickly put in place with Croydon to start to have patients offered Croydon as a default, who were being referred into the George's service. But it's a very fair point about at what point do we alert GPs to an operational issue. And I don't know, but let me look into that.
Okay, looks like that's all the comments. Thank you very much, John. It's very helpful. So the next items we've got on the agenda are minutes of meetings. So we've got minutes of Audit and Governance Committee, and that's for note. Was there anything particular you wanted to say about that, Andrew?
One is full one for March, and then we've got May signing off, and then the July, which basically was summarised here because we haven't had the minutes yet. The only point that I wanted to make was something I've discussed with, sorry. I never get used to this damn thing, sorry. The only thing I wanted to just draw attention to, which I've had some discussions with James about, the fact that we actually had a report that didn't exist. It was basically saying that it was the South West London internal audit plan, but there wasn't one actually. And I was raising the question of, how we could be engaged with it next time. And I think, James, you might want to say something about that.
Yes, so the plan came out, but it came out in July, which is clearly quite late. The issue this year was that we had the procurement process, which didn't finish till March, which obviously left us quite late. And although the audit plan was largely based on what they'd put in their procurement process, we then didn't pick it up in the May final accounts sign-off. So I think there's lessons to be learnt there about how we do that a bit slicker next year, but there were some mitigating circumstances, so we'll do better next year. But I mean, it has gone through, it was shared with local management teams, and just to clarify, it is an audit plan for each CCG, so although we look at it across South West London, there's a clear work demarcation across each CCG.
I think the point I was trying to make was to make it clear to this board here that we haven't actually seen it. It might exist, but we haven't seen it, and I think you should know that. So I'm sorry, but
yeah, it was in the July papers, though, wasn't it, Fraser? Yeah.
Okay. The papers for the July
Audit Committee.
Audit Committee.
Yeah.
When's the July audit?
So it was late. I mean, there's no doubt about that in terms of getting that through to the committee, but it has gone.
And what are the implications of it, and what we're going to do next year? I'm assuming that we're unlikely to experience the same sequence of events next year.
No, we won't experience the same sequence of events next year, so we'll get that all aligned and we'll get that through before the end of March. And also, hopefully, touch wood with the next item, we'll have a joint committee it can go through and get signed off through that basis.
And Andrew, if there are any ongoing issues for Merton in relation to that, maybe we could just pick that up after the meeting with
yes,
James and just have a look at that.
Yeah, I mean, you've covered it in the joint committee item, which is what I think Fraser's referring to, but it didn't exist in the audit committee. And I think one of the issues for the audit committee is it doesn't have relevance once most of it is going through the South West London Committee in Common. There's the question mark of, what is the role of the CCG's audit commission, because so much of the material will be covered there. I don't have a quarrel with it. I think this board needs to know that that's what's happening.
Should we pick that up when we talk about the proposal to establish the audit committee in Common?
That's what I'm suggesting.
Yeah, that's fine. Okay. Any questions or comments in relation to the minutes that you've seen? No? Okay, I'm going to move us on to, we've got the summarised minutes of the Integrated Governance and Quality Committee. You've got 3 sets of minutes there, and there's very helpful summaries that are attached here which really pick out the key areas that have been discussed. Was there anything specific you wanted to say, Julie?
It was just really to say how we've been reviewing the function of the meeting and how the meeting works now that we've pulled the two together across Merton and Wandsworth, and then the development of the subcommittee, which is now a joint committee between Merton and Wandsworth. A lot of work on how we manage risk and where we take risk for escalation and de-escalation has been discussed. But basically the format in which we take the format that we use and the information that we take has been really important to the committee now. So over the summer we did have 3 task and finish groups which looked at finance performance and quality and how we present that information to the committee. So I think we're in a better place than we were probably at the beginning of the year when we were trying to work that with two different organisations coming together and having very different ways of managing that meeting. So a lot of progress being made, and I think it's working better now than it did a few months ago.
I'd certainly concur with that. Chairing the meeting jointly with Nicola on alternate occasions, it's definitely moved forward significantly. I think the time we set aside to work out what we wanted to see there and to get the quality subcommittee going was time well spent. Did anyone have any other comments or questions? No, well, we'll take those minutes as noted then, and let's go on to the next item, which is the Governing Body Assurance Framework, which is for discussion. Is that Julie or Fraser?
I mean,
Yeah,
I've got a bit of a role with it today, so I think Fraser's going to cover that. And just to say that there's been a huge amount of work put into this as well, and I'd like to think that it's now a very live document and a document that does have a true reflection on the organisation. So once Fraser's presented it, it would be really helpful to get that feedback to see whether people feel like that is Merton and whether they like the format that it's in as well and whether it does what it's here to do. So I'll hand over to Fraser.
So what I was going to point out is that, so we're clear in the process that it's a mandatory requirement for us to have assurance framework, and we will bring it here every 6 months. So this is the latest iteration of it. There has been quite a lot of work around risk over the last few months. The basis of the assurance framework, of course, is for us to see where we are in terms of our, in terms of achieving our corporate objectives. And to do that, it does use principal risks from the risk register as the foundation for making that assessment, with a key focus around the level of control we have in place and the assurances that we receive against those controls and how effective they are. And just to define so everyone's clear, that principal risks are risks that have an inherent, so before we consider any sort of mitigating actions that we have, they have an inherent risk score level of 15 and above. So that's our red risks, our top level risks. The other thing I was going to sort of point out, I think Julie already clarified already that the IGQC is the main committee where we discuss the process around our risk management system. So there's been a lot of work there, and so the people that are on that committee will be aware that we've been taking a lot of risks, and they'll be fully aware of the movement within the risks over the last few months. This obviously is just 7 of those, so to be clear that this is not the complete number of risks for the organisation. There are a number that sit underneath this. But the document itself, and hopefully now that I've made a few tweaks to how it's formatted, it should be relatively straightforward. So it starts on the first couple of pages with just a table which shows the principal risks and how they map against the individual corporate objectives. And then following that, each risk has its own page, which provides a little bit more information and detail in terms of where we are. The structure's changed slightly in there, and I'll just point out a couple of things. So what I've done now is I'm mapping assurances and controls together so that we can be a lot clearer in terms of what elements of the control that we've actually received assurances against. The benefit to that is also that it helps us to see elements of control that we're saying we have in place but we haven't actually received any assurance against, so we can start thinking about how we might enhance that to a greater level. We've also done some work around putting some target risk scores in place. The system that we use, the computer system we use for recording risks, has a mechanism where we enter in actions, any further actions that we want to take on risks. it asks us the question as to sort of what the impact on the risk score will be by implementing those actions. So that gives us a sort of a driving point for thinking in terms of what that target risk score is going to be. But there are other factors as well to consider in terms of, as I've already mentioned, enhancing the level of assurances that we have in place will also help drive that confidence level and take that target risk score and the residual risk score down. The other element is that provide a little bit more focus on a conclusion at the bottom, so that you've got some clarity around why the risk is as it is and where it's at, and what we're planning on doing and working on going forward. And as previously had been reported as well, we've got target dates for mitigation against each of those risks. So I wasn't going to go through any of the risks specifically in detail, and we could probably just move to if anyone's got any questions they want to ask.
So, Fraser, just to kind of summarise it, if we're not seeing corporate objectives here, it's because we're fairly confident they're going to be delivered.
So I think it's to be clear here, because we're pulling out just the principal risks, so we're the big risks. There are risks against each of the corporate objectives, but they will be a lower level. So there's a selection of lower level risks that are managed through our committee structure anyway. So that would be the reason for that.
And just help me understand how this sits against the requirement for the governing body to review our achievement of corporate objectives. And what we've said is we will go through the BAF in detail twice a year, really as a way of checking how we're performing against our corporate objectives. So how's that going to be managed as we go through the year?
I think there's two things.
Is this it? Or I think what you're showing us is here's the refreshed version, this is how it looks like. Do we have a plan to... This
is a position in time. So behind this, what you've got is a live process that continues. It's part of the risk management system. So we review these risks on a regular basis. And we're in constant discussion with the relevant directors and leads as to sort of where we are in terms of these risks and how we're managing them. And I think the reality is to make sure that this is really a collective of information that you're already receiving. I mean, as you see today, the information we've received refers to a lot of these risks. Neil's already talked about the finance ones, we've had mental health, so it's not supposed to be something separate to that. This is really just pulling everything together into a document that says, here's our overview in terms of the key risks that are likely to impact on the achievement of our objectives. So it's part of a process. So we will bring this back every 6 months. The risks are time bound, but not all on an annual basis. So some will run longer than others. So there will be some movement in terms of the risks that you will see within that. So it's really, this is a position, all I'm saying really is this is a position statement in terms of where we are, but it is a live process and it continues throughout the year.
I guess what I'm reflecting on is maybe not something we've got time to properly sort out now, is how are we as a board going to use this, and how are we going to reflect on this and think, are we as an organisation doing everything we can to make sure that those risks that continue to exist despite mitigations we are planning for?
I suppose from that perspective there's an opportunity here for you to look at this and if there's anything that we believe for one is missing from here and we want to ask the question as to why, then yes, we'll address that. Or otherwise, if there are any specific concerns within here as to sort of whether we feel that the risk position appears right, or whether we've got any concerns that what we're actually reporting is a risk level, because the first thing I would do is look to say, well, which are the ones that we're still currently managing at a high level, and they're the ones that that we're probably saying is the highest likelihood will have an impact on our objectives. So
I think I'll open it up for other questions and comments. I think what I will take away is when I do the work with James and Josh thinking about the forward plan for the board, and we're looking to take a more strategic approach, how does the board assurance framework inform what we are focusing on?
Yes, and that's really where we want to get to.
So following on from you, Andrew. So if I look at what 152, which is financial balance, inherent risk is red. Fine, I wouldn't argue with that. But the residual risk, I would, that's been risk assessed as still at the same level. And then under further actions, none noted. That can't be right. It can't be right. And so I think it's partly around what is our process for assessing the risk, and then what are we reporting? Because if I was anyone external looking at this, I'd be turning around, to James and saying, well, what's going on here? You're actually saying that you're not taking any action, and that's not correct. So there's a point around, I think it's got to be correct. The issue then, how do you then assess that residual risk? And are we really saying on the financial one that, just 4 months into the year, we're saying it's ending up still red? Now, if you say, if the view of, if Neil and James's view is that is correct, then I think at the Finance Committee we need to talk about, so what is the impact of that? Because, but we haven't had that discussion. So it may well be a timing issue, but I think there's a principle here in terms of, how are we assessing the risk and how are we reporting it?
Just to say from a process point of view, each risk, so the finance risks should be signed off and agreed at the Finance Committee, and that's where you should look at them and agree the scores, etc. And then they would go on, if it's a BAF risk, go on to the BAF or come through Integrated Governance Committee, and that's where we would, in a sense, rubber stamp the escalation or de-escalation of any risks. Same for quality, for example, we would do them at the quality subcommittee, and then they would come up to integrated governance, be rubber stamped and done that way. That was the process. But to be fair, we didn't really have a very robust process in place until, well, we put it in place now. It was feedback that we got from last year's audit around risk that we didn't do that very well. We didn't have a proper process for escalation and de-escalation. So it's just gone into the terms of reference for the Integrated Governance Committee. It probably needs to filter down into the Quality Subcommittee, Finance Committee, that's a function of that committee now.
I mean, just to pick up that point, because I think you're right, the residual risk score should be different to the inherent risk score, because clearly if there's controls in there, I would expect that to be lower, but I'd still probably want to still be flagging it as a risk. I think the other issue was a timing issue, because I wasn't around when we put this together, so I think we'll do another review of this and ensure for the next Finance Committee this month that we'll have done that. So hopefully you'll be more assured.
No, so very happy with that, and we can pick that up at the Finance Committee. But again, there is a principle, isn't there, that if we've got something, we're showing up two very, very high risks, then for us as a board, surely what we should be saying, we ought to be coming back to each board, well, where's our recovery plan? Are we doing everything we possibly can to reduce that risk? And we're not flagging. I don't think we're flagging this up enough in here. And I just make the point, because we're not the only ones who look at this sort of stuff. Our regulators look at this, so we've got to be quite careful in terms of what we're playing in. I accept there's a timing issue that we need to pick up, and then we'll pick up the detail near the Finance Committee.
Yeah, and I think let's have a conversation outside the meeting as well about what we do that and how it informs the work we do and the conversations.
Yeah.
Okay, anyone else? Katie.
So I was just going to add that it might be helpful on that point actually. I'm pretty sure when we went through the primary care risks, you could pull a report that actually showed which risks had been sort of escalated or de-escalated over a period of time. And I wonder if that would be helpful to show up in future formats of this report, so actually the board could be assured that where things may have dropped down or have gone up or have been on the list at the same level for a period of time, you could actually reflect that, and that might help with the kind of the ongoing understanding of what's changed, I suppose.
Certainly that's something that we can bring in terms of what you mean in terms of showing whether what the movement in that risk has been in times, or whether the actual risk.
Well, I was just saying if the point David was making was that something's been on the list at a very high level for a very long time. There may well be things that actually have come down, and therefore you can see that's actually been effective, but I don't think that's currently reflected in the report, what's actually come off the kind of the top risks, so whether it'd be helpful to report.
Yeah, I think that's a fair point. One of the other things that we're looking at in the integrated governance was where we look at the whole risk register and where we see the variation. So we do need to think about that. We clearly wouldn't bring the whole risk register here, but we do need to think about how we do get a view on that across the organisation. And we did think that was integrated governance committee, but then we wouldn't want to take that every month to integrated governance. But I think we do need an overall picture of it, and your point earlier about so what do we do with this, we need to go away and think about how we can evidence how we're achieving against some of them as well, and doing a bit of an evaluation, and so that we can present that to governing body, but we'll have a think on that point, because I think it's a fair question.
Thank you. Right, I'm going to move us on to we've got the final two items, which is around the establishment of committees in common. Can I suggest we do the finance committee proposal first, and then do audit?
Shall I do them both together, and then we can pick them up and pick up any issues, because there's a lot of commonality. I'll end up presenting the same thing.
Yeah, why don't you do that then?
So we've talked about this quite a bit in terms of setting up committees in common. The purpose of it isn't to hinder local accountability at all. It's committees in common, so they're concurrent meetings. And we're looking at the moment to start having audit and finance, so they'll alternate between a system meeting and either a local meeting or a committee in common, local committee in common meeting, if that's what you have. And there's still, and I would expect when certainly CCGs have got particular issues, that if necessary, they would have to have extra meetings as required. So it's not looking to do that. What it is looking to do, though, is to bring together a lot of shared learning, consolidate a lot of experience. When you sit with the 6 audit chairs or the 6 finance chairs across South West London, you've got a lot of experience around that table, and given the way things are moving, we need to make sure we make best use of that. It does allow us to drive through some efficiency in terms of how we're working, and make ourselves more coordinated and drive more value out of the audit plans or other plans. In terms of some of the flows, some of the things we've talked about and have been raised as we've taken this through the other governing bodies, clearly information flow is important. We don't want to overwhelm people when they've got a system meeting, so we've had conversations with RSM about how they can present reports to the system meetings in a much more succinct way, so you don't get 6 versions of the same report to work through. And similarly, we've started some discussions with finance chairs about how we can present some of the information to that. We're currently developing the terms of reference, doing this various courtesy checks, and we'll get legal advice on all of those, on both of these committees. And on both of them, as we start in October, when we look to start, we'll review them as we go on after every meeting. Both of them will have an alternate chair, so we'll have alternating chairs as we go through. And again, key is, from what we've discussed with others, particularly for Finance Committee, where there's procurement issues that you would want to make as a decision at Finance Committee within the rules, you would still do that. But clearly when there's bigger, more controversial issues, we'd expect those to come back to governing bodies from a common meeting, but to take soundings from governing bodies on how you want to move forward on some of those. So that's the sort of general points around those. And where they sort of differ, I guess, is in terms of the audit one, we would have 2 reps on that, the chair or a nominated deputy plus a nominated representative. Again, alternate meetings, but the view was that the chair would alternate every meeting on that, so it would swap every other meeting. And just to emphasise the point that I was making earlier, you still have a separate audit plan for each CCG, you still have separate audit plan reports, all those things will come back, and critical to this is we still operate as 6 statutory organisations, and whether it's Andrew or me or David, we need to give assurance to the board that we've got a real grip of those issues. So as I say, we'll monitor that as we go through. In terms of Croydon on the audit one, we've run this as a South West London approach, but we will invite Croydon to this one, so they will, and I think they will attend, but we've made an invitation to them. Finance Committee is slightly different in that, as we know from the planning guidance last year and the way things are moving, there's much more focus on system working. There's much more focus on control totals and how we have to balance those across South West London. And clearly, as we move to working together, as we've seen around some of the procurement issues, we want to look at those across the system, not just in one CCG. So, for example, with Sutton, we've started talking about the 111 re-procurement. We're only talking about it as Sutton because they actually are the host, but it's a key issue for all CCGs, and all CCGs ought to take a view on that. Again, 2 reps on this one, but what was quite clear from the finance reps is they wanted to maintain a strong clinical involvement, so we would be looking for a lot of, a strong GP representation, so it doesn't become a committee that's very distant from our clinical representatives. Excuse me. And although we'll alternate the chair, again, the proposal was that we'd alternate it every 12 months, because clearly with finance, as you're working through a cycle of business, that it was felt there would need to be a continuity to that. And Bob Armitage has volunteered manfully to do the first 12 months on that, subject to ratification. The only other final point to make on this is clearly Croydon are part of South West London when we look at control totals, when we look at a lot of other issues. So they have been part of these discussions. They're very willing to attend and take a full part in this, and therefore that they are fully involved in this one, slightly different than the audit. So that's the kind of overview. I don't know if which order you want to do it in. If there's anything that David and Andrew want to add to that from their perspective.
So yeah, there was a discussion just of the Finance Committee chairs. I think our view would be there is a need to have something like this across South West London, and we need to, for the reasons James has mentioned. I guess the question is going to be, how does it really work in practice? Because I don't think anyone's going to thank any of us if we end up having a Finance Committee and in the same month we also have a local meeting, because all we do, we put in 6 more meetings and none of us, including me, are going to want to do that. So how do we make this work in practice? And it may well be in some months that actually you do have to have that. I would hope that in other months then we can flex it a bit. I mean, it's pretty clear. If we looked at, I think we had a meeting in April and May, and you think, well, there's no business. What's the point of that? It's a waste of everyone's time. So I think there's an issue of how do we get this to work in practice and make it as slick as we possibly can. And I do think, James, you're absolutely right. It will rely on the clarity of the information we get, because we, just thinking through, if we've got, presented to that committee 6 positions of each of the CCGs, there's a real danger of overload, because we'll know our own bit, we won't know everyone else's. So we've really got to get this information very, very slick. So I think there's a point for me of there's a bit of suck it and say, let's start this off. Let's try and get it as slick as we possibly can. On the issue of the clinical membership, again, I don't think it should be a committee just of the 6 chairs with James and colleagues. So how do we then? Is this then the chair of the CCG joining it, or is it one of the other is it another GP board member? And then do we actually have the same person each time, or do we say, well, actually on this board there's 4 GPs, it can be any one of those who are coming to that committee? There are pros and cons about that, obviously, about continuity. So we need to work that through. But I think, as I say, the general view, we need something like this, but it's how it works in practice.
Yeah, I mean, I think we're supportive of it, but I think there are 2 issues. One is logistics. I'm all for saving people journeys, but that doesn't drive the whole ship, really. And the other thing is about content. I mean, if you've got this overarching committee, how much of it is going to suck it out from the main from the local committee, and then what's left, we don't really know. I think we should try it out. I also think it's been quite good on the planning side in terms of timing. There hasn't been an excessive number of meetings set up. So I think we'll just try it out. But I think we need to be aware that this board has a committee that's labelled audit, and it has a responsibility to do things. It can't just pass it up the line, as it were.
Yeah, go on, Sarah.
So just to be absolutely clear, this is the Audit Committee and the Finance Committee, but they're just meeting together with other committees. It isn't a different committee, it is the same committee, it's just that it's meeting with other committees alternately. And I just think we need to be careful. It's not a joint committee, it's a committee in common. So we have 6 committees across South West London for both Finance and Audit. When they meet in common, they are still the same 6 committees, they are still the same local committees as part of the governing body, and it's part of our constitution. So it doesn't change that, it just means they're meeting together in the same room.
So I agree with that, and I'm supportive of the proposal. What it does mean, though, although in governance terms we retain the separate committees, in terms of setting the agenda and the focus of the discussion, it will be different. Yeah. I wonder whether we might, given we say we're sucking it and seeing, whether we might actually at this point say, should we actually agree to review it? So to say after 6 months, after 12 months, we will from now say we will review this, and it's not a given that this is what we do in perpetuity. We're trying it, and I think that might give people some assurance that this isn't an inexorable path to bringing everything together and merging everything. We're trying a different way of working to see if that works more effectively, and let's review it. In terms of we can have a conversation about outside the meeting about who services this. I do think there is something, particularly with finance, in terms of continuity, because you're following the story through the year. My first reaction to your question about whether you alternate or not would be probably not. We might want someone you might want a deputy to fill in, but I think we might want someone who can really grasp it and track it through the year. But we can talk about that outside.
So on the review, I think that's absolutely right. What I would also say is we're not expecting them to be doing the same business. And one of the issues that's come up in other governing bodies is this. So this is the 4th one that we've discussed this at. Is that actually they welcome this because they feel that there is stuff that currently isn't being seen. So there is South West London level. I don't know if that's true. I think it's probably going through all 6, but that there is an opportunity for the 6 to share and do things differently, particularly where we're looking at things like STP level work that we're doing, or where we've done procurements across South West London. So there is an opportunity there to bring some of that together and to really be more efficient and to do things in a different way that will actually be of positive benefit to the way in which we work. And I think that's important why we do the review as well, because if we're actually not achieving that, there's not much point in us doing it, would be my view.
Okay. Any other questions or comments? Do people feel they understand it well enough to be able to approve it? Okay, let me ask you about both proposals then. First of all, the proposal for the establishment of an audit committee in common. Are we happy to approve that? Yes, with the caveats that we've said in terms of reviewing it. And then 10.5, proposal for the establishment of a finance committee in common across the Alliance and Croydon. Are we happy to approve that? Yes? Okay. Right, that's the end of the agenda. I haven't been notified of any questions in advance. I'm going to move to close the meeting, knowing that we have to move on to a part 2. The date of the next meeting is Wednesday, 7th November, and thank you everyone for your time. We'll take a 2 or 3 minute comfort break, and then we will move straight into part 2.
Yeah, help yourself.